So, good morning. Thank you and for inviting me to this, I think. Um, and also, I actually accepted, so that's something that I need to talk about. So, Battle Royale, these are my financial disclosures, but my actual disclosures are here, if I can show them. So, my conflicts. I am an optimist. I'm going to be an optimist that everybody's fair in terms of assessing how we're doing in terms of TPN. I am a medical oncologist, and I think that that makes me in the 10% minority. I'm also an optimist that Al believes in evidence. And it's a little bit like, the medical oncologist at a Gynecology meeting, looking a little bit like this. I'll let you decide which one is me and which one is Al, and how we're going to end up at the end of the day. I also... I'm going first because I think that it's my opportunity to sort of talk about. So why are we actually debating this? I think what are the things that we want to get out of? Why do we use TPN? And I think that it would be great to sort of talk about what are the opportunities in terms of using TPN, where is it used, and how do we actually look at it objectively in the context of patient. And at the end of this, I think that really get some sort of consensus in terms of what is appropriate in terms of using TPN. So when I was sort of thinking about how should we sort of look at this debate and this talk, it sort of reminded me in terms of the Seinfeld episode, No Soup for You. And I think that hopefully a lot of you have actually seen this. And sort of, it actually looked like Al as well. So I think that really it's very, very clear that some people have very, very strong opinions. And often those strong opinions are based on the fact that they're just strong opinions without really any evidence. And I think that in truth, probably if we sort of come down to it, at least I hope that in truth, that there is some reasonable agreement between Al and myself in terms of what are the sort of settings in which we might be able to consider TPN early in disease, perhaps perioperatively. I think that there's little debate about that in the appropriate setting, particularly if the likelihood of treatment, particularly chemotherapy and surgery, is going to be a long-term control of disease. I think that there's little debate about that. But I think where we often get caught up in terms of debating this is what do we do in the setting of advanced disease, particularly malignant bowel obstruction, and when should we be considering it, particularly when patients have bowel dysfunction, and how do we sort of balance what are the patient needs, wishes, quality of life goals, and palliation, and when should it not be used? And I think that there's little debate about the fact that in patients with advanced cancer cachexia or patients who are dying because of advanced disease, in the absence of bowel dysfunction, there's sort of really probably little role for using TPN. So how did TPN first start off? And sort of looking at this, TPN started off a very, very long time ago. I think that from the initial sort of demonstration of the circulatory system by William Harvey several hundred years ago, there were sort of attempts made in terms of trying to sort of infuse things intravenously. And in fact, when I was sort of looking at this, the very first TPN type of clinical trial or assessment done in animal models was infusing wine and ale into dogs. I think that was more as a reason for trying to look at anesthetic type of uses. But probably the first sort of infusion intravenously was related to wine in many, many years ago. But in fact, looking at TPN evidence, it probably really started about 50 years ago in the 60s in terms of working out the mechanics of being able to infuse nutrients intravenously so that they would actually help support a patient. And over the last 30 to 40 years, it's become well established in different settings in terms of using TPN. And there are sort of very, very good guidelines, both in terms of developing TPN and TPN bags and how to use these. And also, increasingly, we're sort of looking at TPN and being able to deliver it in a patient's own home setting so that it can actually be done conveniently. Initially, when TPN started, it was given over a 24-hour period, but increasingly, patients now receive it over a shorter period of time. And as I said, it's really the last 50 years that have really demonstrated that the safety and efficacy of actually using TPN. And there is sort of a fair amount of evidence that if in certain appropriately selected patients, that if you actually give the bowel a rest, particularly if there are complications related to fistulization and things, it does allow appropriate time for the body to heal and repair itself. There are probably other sort of uses that will emerge. But it really should be used in the setting of when do you need to sort of provide patients sufficient nutrition, particularly in the setting of bowel dysfunction, and where would intravenous supplementation be useful. I think that there are guidelines for use in terms of perioperative setting, but there are very few guidelines that really help us determine how do we use these in an advanced cancer setting in terms of palliation. And the data in oncology are conflicting. And the evidence in oncology is a little bit conflicting when we should be thinking about TPN. The settings in which we're particularly going to be sort of working in gynae-oncology are in patients who have small bowel obstruction or have bowel dysfunction with malignant bowel obstruction. And in these settings, there is some evidence that giving TPN may be useful, particularly in patients who have distinct biologies, such as low-grade serous cancer. The evidence in terms of more advanced disease, terminally ill patients, I think is very variable, and I think these are the settings where we should be really cautious about using TPN. Patients who are going to be receiving multimodality treatment where there is short-term support that's actually needed, again, the evidence for this is generally very good. And overall, it seems that interventions such as chemotherapy and TPN may be appropriate if patients are carefully selected. And I think that this is probably the main challenge in terms of how do we carefully select patients where they may benefit from TPN and balance the implications of using TPN, particularly in terms of the impact and quality of life, and how do we sort of make sure that we don't use it in a setting where it's going to be futile. It's also important to recognize that TPN has changed, that it is easier to start now. It can be started on an inpatient basis, but also it can be started on an outpatient basis, providing the support systems are in place. Home TPN is, in fact, very, very well organized, particularly in the sort of home care Toronto areas, and other settings could expand on these. Using TPN in short term, over 6 to 8 hours, and patients can remain very active and ambulatory during the course of the day. And the costs for these are sort of modest in comparison with many of the other treatments that we use now. But it does require supervision, and it does require a team that's expert at managing TPN. And I think that we have a number of examples, and again, the debate started from Princess Margaret because we have been using it. And the two pictures here are of two different patients of ours who received TPN for a significant length of time and benefited. After lots of discussion, the first patient was a patient with platinum-resistant disease who had essentially a 5-year trajectory of disease, which is very similar to what we see in practice with patients having multiple recurrences and advancing disease. And she developed bowel obstruction and obstructive symptoms, but was otherwise very well, and there were opportunities to sort of look at treatment. But in the setting of bowel obstruction, we had a discussion. There was no surgical solution. And so she was supported with TPN, and she, in fact, remained on TPN for 8 months, had a very good quality of life during that time, and was able to do everything that she wanted to in the context of somebody with advanced disease. Another patient also had TPN again towards the end of her life, but again in the context of when she was still being treated, actively supported with chemotherapy, but was unable to eat and remained on TPN for 5 months and maintained good quality of life and remained completely ambulant, including traveling to lots of different places, including Europe and China, while she was on TPN. We sort of, in order to try and formalize our management of malignant bowel obstruction, we essentially set up a malignant bowel obstruction program, which is a unique proactive program to look at managing patients with bowel dysfunction. This is a multi- and interdisciplinary program in our center. And it's really to try and look at patients who are running into trouble with malignant bowel obstruction, and how do we sort of really assess them upfront before they actually run into trouble with bowel obstruction, try and avert it if possible, and support them as needed. It's a very, very complicated algorithm that we've developed and recently been published, but the bottom line is that we sort of look at a very careful assessment and triage of patients as they're developing increasing symptoms. And this is predominantly done by our nursing colleagues who have developed a color coding system where the patients who are running into trouble are sort of essentially coded between green, yellow, orange, or red, depending upon the difficulty that they're having. And this sort of sets the trigger in terms of really looking at it as a sort of multidisciplinary team in terms of what are the opportunities for management and identifying what support systems need to be needed. We've actually set up malignant bowel obstruction tumor boards, which are held on a regular basis. And this allows us to really look at how do we support these patients, both in terms of diet. Is there a role for surgery? Is there a role for limited sort of interventions like stenting? And is there a role for potential support and TPN? Palliative care also participates in this, as well does the TPN team. And we recently published the data related to the first sort of couple of years of experience of this. And the sort of findings from this show that proactive management does help, including, and this did include TPN in a proportion of patients. About a quarter of the patients received TPN. But we found that by proactively managing patients as a sort of team, we reduce the length of stay that patients are admitted for in terms of bowel obstruction. We reduce the complications that patients have. We reduce some of the costs. And most importantly, we reduce some of the sort of challenges and friction between medical oncology and surgical oncology that often used to happen when patients were admitted with bowel obstruction at 3 a.m. And in this, I want to emphasize that there were patients who received TPN, patients who did seem to benefit, and a proportion of patients, about 27% of patients, received TPN for a duration of 6 months or longer, and the longest lasting patients on TPN received it for about 2 years. And it's hard to sort of say that it was not worth it for those patients. So we have sort of really formalized this assessment, selection of patients, and then supporting these patients, particularly when they're having TPN at home, seeing them regularly, and looking at opportunities for palliative treatment during that time. The important aspect related to cost was also factored in, and in terms of the malignant bowel obstruction program, we found that the costs during the time that they're actually being actively managed in this MBO program were lower than our historic costs from 2 years before. So it does seem that appropriate selection is the key in terms of identifying treatment. So this is my sort of last slide. I think it's fair to say that level 1 evidence in terms of use of TPN in an advanced palliative setting in gynecologic cancer is somewhat missing. I think that TPN in gynecologic malignancy in advanced disease is feasible, but it does require careful selection of patients. I think this does require multidisciplinary and proactive monitoring approaches for patients who have bowel obstruction. It does not necessarily need to increase costs, particularly if we look at cost effectiveness and select appropriately. And I think that it's important to consider it for the right type of patient. So I'm going to stop there. I think that everybody's on a high in terms of the Toronto Raptors, and this is part of our gynae team that they sent this after I left the hospital yesterday. So preparing for Battle Royale. Over to you, Al.
How do we change the slides? Oh.
Yep, sorry. Green. Maybe I should take that away.
Thank you. So I've kind of refined the title a little bit from what Helene originally gave me, because I think that this is the population we're really talking about. And I'm going to start by asking, is there anybody else in the audience, other than Amit, who gives these patients TPN in some type of routine or regular basis? All right. One?
Two.
Two? Oh, I didn't see who the other ones, but okay.
Three.
Three now.
Come on. More.
More. So, as best I can tell, I can probably sit down. There's really nobody to convince here.
There's everybody to convince.
Why, when I hit the button, nothing happens?
Fixed.
I have no disclosures relevant to this. And here's the objectives that Helene modified. I won't read them. So, as the official G1 oncologist of the Toronto Raptors, I want to thank the nation's support for the team, and I'll have you know that I sent these slides to Helene on Wednesday, so I knew full well that they would win on Thursday. So I'm going to make a couple assumptions here. I mean, I think, Amit sort of discussed a bit about managing the patient who's at high risk for a bowel obstruction, not only necessarily at the end of their cycle of the illness, but including some at the beginning. And I think that there's really less debate or difference between us in the patients early on, at diagnosis, platinum-sensitive disease. We're really, in my mind, focusing on the patient who has a malignant bowel obstruction, and surgical management of that obstruction or endoscopic management is not an option. So a stoma, a bypass, whatever. None of those are options. And whether we're talking about platinum-resistant ovarian cancer or other subsets, it really comes down to what do you think the patient's survival is, and what do you think the patient's response to additional treatment, if that's an option, is. And I want to just touch on these four issues: survival, quality of life, financial resource issues, and some of the ethical issues. So, what we're not talking about, what I'm not really going to talk about, is the ovarian cancer at diagnosis who presents with a bowel obstruction, the patient who has a bowel obstruction that could be corrected by some type of surgical procedure, or the patient who's got a platinum-sensitive recurrence. So this is nothing new for the majority of people here. The vast majority of patients with ovarian cancer are advanced at diagnosis. The vast majority will eventually recur and die. For the vast majority, they will develop a platinum resistance, and that's what leads to their death. How long do patients with platinum resistance live? Well, probably the best data we have is from the Aurelia trial, so a prospective randomized trial, and that median survival was 16.5 months. Over 50% will develop a bowel obstruction as their terminal event. And once patients develop a bowel obstruction that's non-amenable to any correction, the typical median survival is about 3 months' time. So I think that those are all important parameters to keep in mind. So there is a Cochrane review, and this includes not just GYN malignancies, but all cancers. And you can see that these are all observational studies. None of these they evaluated are randomized. And when I talk about TPN, I'm really talking about home TPN. I mean, if we really want to drive up costs, we can talk about institutional TPN, but that's really not a long-term solution. So you can see that a lot of patients will develop catheter complications, and the longer they're on TPN, home TPN, the much more likely they are going to develop a catheter complication. A patient who lives 3 months isn't as likely to have a catheter complication as somebody who lives 12 months. And the quality of life data is really rather poor, and that's because different quality of life scales were used in each different study. They were evaluated differently, and you can see it's kind of equivocal. One reported improvements, several reported just as many patients deteriorating as those that were improving. There is a fair amount of data from the late 80s and early 90s looking at randomized studies of TPN in patients with malignancy. And you can see that I've kind of highlighted the general conclusions from those, and you know, this is done a while ago. You can see that they really concluded it was associated with decreased survival, not even equivalent, detrimental effects in terms of increased risks of infection, and it was strongly recommended not to use. And this was the American College of Physicians position statement. They haven't issued a new position statement since that one in 1989, but at that time they suggested there was net harm and there was no conditions which defined it to be of benefit. There have been some newer studies. So this is a systematic review that was done just several years ago, only looking at randomized studies. Again, not just gynecologic oncology. Usually the gynae patients contribute a fair amount of these patients, but you know, there's GI malignancies and other cancers in there. You can see median survival, 83 days. I'm going to be talking about ICERs a lot, and you know, ICERs, we're usually talking about cost per quality adjusted life years. In many cases, the data is really years of life gained because we don't have the quality of life assessments. But you can see that in this systematic review, came to just over 175,000 pounds per quality, which would be the equivalent today of about $350,000. Now, for those of you that are familiar, most cost-effective strategies try and focus on things between 50 to 100,000 Canadian dollars per quality adjusted life year. So, you know, more than that is rather expensive, and less than that is either cheap or within what we're kind of looking for. So, specifically in platinum-resistant ovarian cancer, as Amit said, there are no high-quality data at all. We're really just looking at case series. Many of them do not differentiate between platinum resistance, platinum sensitive, and I never found any proof in the pudding. So I'm just going to go through several specific GYN oncology series. This is the most recent. This is one from Ohio State, 53 patients with malignant bowel obstruction that they're using decompressive tube placements. 28 had complications from the G-tube. 36% had more chemo, 40% TPN, median survival of 46 days. No association between survival and TPN or performance status. This is one from the Mass General, 115 women, 84% ovarian cancer, a high complication rate again from the G-tube, and similar numbers in terms of more chemotherapy and TPN. Survival, 5.6 weeks. The chemo patients, 10-week survival benefit. TPN, 5-week survival benefit. Only chemotherapy was an independent variable associated with survival benefit, not TPN. And then here's data from, this is from Rhode Island, 55 patients with bowel obstructions. The TPN patients lived 72 days versus those that didn't get it, 41 days. In patients who received chemotherapy, again, longer. TPN, 55 days versus 38 days. So you can see a net benefit of all of 17 days. And then the next two are Sloan Kettering data. This is probably a little updated from an earlier publication. 94 patients, again, similar numbers getting chemotherapy and TPN. And of course, as the studies become older, the options of chemotherapy are a little more limited than what we have today. Again, median survival, all of 8 weeks. The effects of chemotherapy and TPN, you can see there, they're really quite small. And this is their earlier publication, which probably is included in the next publication. So I think there's some things, you know, we can't ignore the potential complication. TPN is not simple. And so the large series would suggest at least 25% of patients, depending on how long they're on it, will be hospitalized at least once for central line sepsis, occlusion of the catheter. There's a number of metabolic abnormalities which I've listed there, which are not uncommon and need to be diligently monitored. And then most importantly, costs of home TPN. So I called up Kalia. Kalia is the largest outpatient pharmacy in the GTA, which basically provides all the TPN solutions. And the cost of protein, lipids, tubing, and pump rental is about $400 a day. This is 2019 data. Most patients get their TPN administered overnight. A nurse comes in at night, plugs them in, comes back in the morning, unplugs them. So that's 2 visits a day. So whatever type of palliative care and home care they're getting, this is in addition to that. This is all incremental differences. Most patients who are relatively stable on TPN are getting blood work once a week, which I had to estimate that one, maybe it's $100. So you can see that that works out to about $535 a day. The management of complications for line sepsis, this is data from 2006, is 10 to 50,000 depending on how long the patient's in hospital. And today an acute care hospitalization in Ontario is about $1,100 a day. So if a patient with a malignant bowel obstruction, platinum-resistant ovarian cancer lives 90 days without TPN, and we can get them to live 120 or 135 days, and I think I'm being a little generous, but that's just the type of guy I am. You can see that the ICERs associated with that vary from $600,000 to $800,000. And I did not take into any complication data, hospitalization data. So given that 25% of patients will be hospitalized, those numbers are going to be even higher. I'm just going to step back and talk about sort of the 4 principles of medical ethics, and I think people are probably familiar with these, and each individually is very easy to understand and apply. The principle of doing no harm, taking actions that best serve the interests of the patient and the family, autonomy, the patient with the right to choose. And then the 4th is justice, and that concerns the distribution of scarce resources and the decision as to who gets what. And it's the interaction between these that are very complicated. So, you know, the patient that wants everything done regardless of cost, the family that communicates because the patient is unable to communicate, that wants their loved one cared for as if they were a 25-year-old healthy person with a potential long lifespan ahead of time. The interaction between these are extremely complicated. And I'm going to let Amit do his rebuttal. That's my grandson. And then come back with some more information. Thank you.
So I think that Al sort of, again, went through the data, particularly related to disease in an ovarian context. I think that in terms of ovarian cancer, over the last few years, we've recognized that ovarian cancer is not just one disease. There are multiple different disease types and different distinct biologies. And when we're looking at one size fits all, I think we need to sort of really start thinking about, does one therapy need to be uniform across the board? And just as in ovarian cancer treatments, we've started looking at different types of treatments for different subsets of disease. I think we really need to look at the patient with bowel obstruction, and it's not all one size fits all. I'm not saying that TPN should be used for every single patient with malignant bowel obstruction, but there are patients where with malignant bowel obstruction who would potentially still benefit. I think we also need to recognize that in ovarian cancer, we're dealing with a palliative patient population, and many of us will give treatment with repeated lines of treatment, liposomal doxorubicin, where the overall level of evidence in terms of patients responding to disease is about 10%, but yet virtually all of us will look at patients and offer them liposomal doxorubicin when the true likelihood of significant benefit is 10% or less. Topotecan, where if you look at the objective evidence of benefit, the response rates are about 0. So I think that we need to sort of really start looking at what is the true benefit and how do we use it and how do we look at patients in terms of where is it useful. And that's the context in which we set up the malignant bowel obstruction program, because I think that a lot of us have deeply held beliefs, look at data which is 30 years old, and try and make inferences. But rather than doing that, let's gather some evidence. And when we actually started gathering evidence, we found that in our hands, patients, in fact, benefited. The average length of stay in hospitals went down. The number of patients who actually had TPN in our malignant bowel obstruction program was only about 25%, but some of them did benefit, and some of them actually went on to treatment. In sort of preparing for the rebuttal, I was sort of looking at trying to find some dirt on Al, and I couldn't believe how clean this guy is. I couldn't actually find much dirt on Al on the internet, and when I put in covens, the thing that came up was witches' covens. But it did have 2 very good pictures of Al. But in terms of looking at this, I think we have to remember this is, at the end of the day, about the patient, that communication and explanation in terms of when should it be used after discussing it is very important. This is not for every patient. It is feasible in select patients from home and may allow a patient to function extremely well. And the costs, I think that, again, we are making inferences related to the costs, but I think it's really time that we did a proper study. When we actually looked at malignant bowel obstruction management in patients in our program, the actual cost of managing patients with malignant bowel obstruction went down rather than up when you're doing it as part of a structured, proactive program. And I think that in terms of evidence, I think this is where Gynecology group in Canada could probably actually take some steps in terms of gathering some evidence and defining what are the sort of appropriate settings in which we should be using. And at the end of the day, it is about the patient. So we do have to remember the patient. So I agree with all of the things that Al said related to medical ethics and our responsibilities. But we also have a responsibility to the patient in terms of making sure that we offer them treatment when it's appropriate and guide them when it's not. Thank you. It's not fair that you're using your grandson as a...
I know, it's not fair. I'm pulling out all the stops. I got some puppies there too. So here's what I anticipated Amit would say. Our chemo options are now much better than previous, and that's true. There are some patients who live over 6 months, and we need methods to identify them. And as he kind of alluded to, you know, every new drug we're talking about is associated with significant cost. And if you look at PARP inhibitors, if you look at bevacizumab, I mean, they all have long, huge ICERs. However, I have yet to see some good data to convince me otherwise with respect to the argument we're making. So I thought, well, let's recalculate this ICER for home TPN. Let's assume that we're going to get this patient now to live a year, which I think is a stretch, but possible. What does it work out to? $260,000. Again, not taking into any complication data, any hospitalization data. And I don't want to totally fixate on costs, but we, in this country, Bill will understand this, in this country we have to understand that healthcare is a money business, a money-losing business in this country, and that everything can be translated down to cost. If you wonder why your wait times for surgery are high, why you can't get more OR time, why you can't get a CT scan quicker, it all comes down to resources, and resources come down to cost. And I don't need to tell anybody here, but the key to successful management is somebody has to make tough decisions, and we have to use our healthcare resources efficiently and wisely. And it's a problem. It's a problem provincially, as healthcare is all directed provincially, because it doesn't follow rules number 1 and 2 of the political playbook. Does everybody know rules number 1 and 2? Rule number 1, say and do anything to get in power. Rule number 2, say and do anything to stay in power. And these are tough decisions that the public doesn't want to hear and don't want to make, and so no one's going to make them because it's political suicide. there is no amount of incremental survival time associated with home TPN at the present time that's going to give you an ICER under $220,000. Again, irrespective of complications and data. Now, I think nobody would argue that maybe that patient who is 30 years old and had all of their small bowel removed for some event and is otherwise expected to live a long life should be denied home TPN, but that's going to cost the system a lot of money, over $220,000 for each year gained. And I think it comes down to some of our obligations where, do we need to offer everything regardless of the cost? And who makes that decision? Sometimes these are very tough decisions. I mean, it's easy when you and the patient and the family are on the same wavelength, but that doesn't always happen. Sometimes patients want to be very aggressive for that extra 2 weeks of life, that extra 1 month of life. And those are very tough decisions. Thank you.
So thank you for the presenters for that excellent debate. So at the beginning, we had a show of hands who would offer the malignant bowel obstruction in the platinum-resistant patient to home TPN. Could we have a show of hands who might offer that patient now? Has there been anybody's going to change their mind, or who's going to offer TPN or is going to use in their practice? Is anybody going to do it before and going to consider doing it now? So have a show of hands, please.
Come on.
Who has anybody got any questions or comments about they would like to ask the presenters before? Please come to the microphone. So I'm going to go to Diane first because you had the last question.
Thank you both. I think it was great and very thoughtful. And in our center, we have occasionally used TPN. But I would just like to point out what Amit said, which is that it's not one disease anymore. And the people that we have tended to use it are the low-grade serous, performance status 0, lead belly, etc., young. And I think there will always be those exceptions. And though I appreciate the hard decision and the costs involved, it's very difficult in that particular situation to deny it. And I just wonder if other people have had similar issues.
Thank you. Marcus, unless there's a comment.
Thank you.
Well, I don't disagree. I think, we're trying to make a statement on a generalizability situation. You're always going to find individual patients who don't fit into a round hole or a square peg that you're going to make an individual decision based upon.
Yeah, so I think following a little bit on what Diane's saying, and I think that I must admit, obviously I work with Amit, and so when I began to see these cases, I remember we were in a room together, and he'll probably say I was a little bit flamboyant in my response and kind of saying,
WTF?
Look,
You never.
do we have an ethicist in here, and why are we doing this? And but I think in my experience, and I think the MBO program has really been very exceptional, and I think for centers that have interest, I think discussing with the group how they did it is really impressive. And I think what has sort of dawned upon me is that the types of patients has changed a little over time. Maybe it's because of the treatments, maybe because of there is no question that with ovarian cancer patients, a large percentage of them, their issue at the end of life is bowel dysfunction. And taking that out of the equation, reducing the complications, I think some of the data of the complications, older data, I think obviously they still may exist to a certain percentage. And it is difficult when you have a patient that comes and they say, can this make me live longer? And, maybe it's 3 months or 6 months. And the answer is maybe. We don't know for sure. And my quality of life is good. It's difficult certainly to get them off it once they're started. It becomes almost impossible. So my question to that, Amit, apart from the fact that maybe we should do a study at the level of the GOC and ask the question so we can get to the bottom of it, but do you have a formal way of establishing who you offer to or not, because if you do believe there's a benefit, it's almost that it should be offered to, or at least considered for everybody when it gets to a certain point, or is it ad hoc?
It's not so ad hoc. So in terms of the MBO program, the whole reason for having those discussions as interdisciplinary discussions, including palliative care, is the appropriate selection of patients who may benefit. And it is a difficult decision. There are many patients where they are functionally extremely well, who you are still actively treating with systemic therapy, but they have major bowel dysfunction. They can't eat or drink, but yet those patients are still being treated with systemic therapy. And I think that in that time, if you are going to offer those patients palliative treatment, then I think it's important to make sure that they're supported during that time as well, so that they're hydrated and that they actually have nutrition if it's appropriate. So if you're going to make a decision about continuing on a patient's treatment with systemic therapy, then you have to make sure that the patient has the best chance of actually being able to be treated. And because of that, we've sort of, in a number of cases, actually offered them TPN. The number of patients who have TPN is not huge. It's not every patient with malignant bowel obstruction, and it's not every patient with advanced resistant ovarian cancer. It's patients who have bowel dysfunction, oftentimes have many sort of challenges related to that, but otherwise their performance status is good. And after a deep discussion, and patients don't go into this lightly because it is a fairly heavy burden of responsibility on the patient in terms of having somebody come to your home, being hooked up and unhooked every day over a period of time. But many patients, in fact, have been able to receive this treatment, and particularly in select patients, they have benefited greatly. So I think these decisions often need to be individualized. I think that when you sort of look at it in aggregate, it's very hard to sort of demonstrate the evidence, but I think this is where we do need to sort of look at what are the sort of goals related to palliative management in terms of TPN, and sort of try and see if we can actually get some more system-level data on this.
Hello.
So, fantastic debate, guys. I thought that was amazing. And I'm not too sure that you're saying very different things, actually. But a couple of comments. Firstly, I've used TPN at times when I have treatment to offer people, and a very select population, and that has been a successful strategy, actually, to get them off. But the other point I was going to say is, when I've used it, I've had very specific discussions about the time when we would stop TPN, because that, for a lot of families, is very emotive, for patients, for withdrawing treatment, and obviously there's cost. And I just wondered about conversations around limits for how long you might use it, not necessarily time, but certainly quality of life or symptom-based limits.
No, I think that that's very key in terms of going into it with eyes wide open, because I think that this is where we're not saying that TPN is being given specifically to just prolong life. I think that that's not the real reason why you're supporting somebody. But if you are offering treatment, is to actually support them during the time that they're receiving treatment so that they can actually receive the treatment appropriately. And in patients, we have this sort of ongoing discussion as treatment is progressing. So if a treatment that's being provided is less and less effective, then we're going to stop that treatment. And those patients are often going to request to come off TPN, because if you actually speak to a patient and they're engaged, they're not going to want to continue with TPN for the sake of continuing with it by itself. In patients who have low-grade disease, mucinous carcinoma, where bowel dysfunction is a predominant problem, that's where the disease setting is very slow, and that's where you're in fact looking at supporting them when they have nutritional imbalance. And that may be in the context of patients who are not actually on systemic chemotherapy, because that's the only way that they can actually continue to function.
Mr. Clyby.
Since the cost is such a big component of this discussion and decision-making, can anybody explain to me why the cost of TPN is still so high? I mean, this has not changed since I was a resident 25, 30 years ago.
So I think that that's a good question, and I didn't want to sort of dispute Al's costs overtly, because those are guesstimates, and I think what we really need to look at is the actual cost of TPN. The numbers that I had in terms of TPN costs from our pharmacy were radically different. So I think inpatient, but also outpatient costs in terms of the intervention. I think that the cost is the hooking and the unhooking. Many of our patients will, in fact, hook themselves up and unhook them. So bags can be prepared, and patients have actually bag deliveries, and patients who have Hickman lines, in fact, can hook and unhook them. So I think that there are many different ways that you can actually ameliorate the costs and manage these. And the costs have come down quite significantly compared to when they first started. Sorry, Al.
Yeah, listen, I had nothing. I called up there's specifically 2 pharmacies in the GTA that manage all the home TPN, and I just said, give me an average cost for the 25% dextrose and 20% lipids, and then they said, well, what about the pump rentals? Oh, okay, add the pump rental in there too, because who's got a pump? And then they said, what about the additives, the vitamins and potentially insulin and all other things? I said, yeah, okay, add that in too. So they were very forthcoming, and they said, you know, this is paper money because it's all through what we call CCAC, Community Care Access. There's nobody paying cash for this, so it's their line budgets on all of these things. To no advantage. They didn't even know why I was asking these questions.
So, I mean, I think this is an interesting debate. There's obviously room for some manoeuvre and people's changing attitude, and perhaps it does beget sort of a COP and bowel obstruction, COP and palliative care, to develop some projects to actually sort this out. Thank you very much to our presenters.
Thank you. All right,